want to talk a little bit about diuretics. Diuretics are drugs that induce diuresis, which is urination. So your body naturally tries to retain water because you need water in your body for a number of processes, mostly to keep your blood volume up, because you need blood volume to maintain blood pressure. You need blood pressure to maintain pressure to your brain. You need your brain to have blood supply so you don't pass out, right? Yes, right, of course, right. Drugs that you can use to reduce blood pressure and also to reduce edema are diuretics. So let's talk about how diuretics work. And one of the main things you got to know about the main diuretic drug classes is you got to remember how your kidney works and how the nephron works. Now, the good news is all that stuff you had to memorize about the nephron in A&P really can boil down to just a couple of very key things. So let's take a look at that. All right, this is from my handout. So diuretics, you'll find patients often call them water pills. They'll say, oh, my water pills are doing this because they make them make water. Now, one of the first things I should mention about diuretics is that, remember, when you prescribe a patient diuretics, it makes them urinate. So when would it be a good time for a patient to take their diuretic? In the morning or right before bed? In the morning, because if it's right before bed, they'll be up all night peeing. So, and excuse me for using the word pee, but most patients will say pee. So that's how I'll talk. Remember that. Be kind to your patients, because they might not know that they could just take it in the morning. Now, kidneys are very important. You constantly are making acid in your body. Within the cells, you have cell metabolism. Not metabolism within the liver as in pharmacology, but cell metabolism, that is the Krebs cycle and ATP production and all that stuff, right? So that makes acid all the time, very quickly. And you need your kidneys to get rid of that acid all the time. And you filter out your bloodstream. So your kidneys are so important that almost a quarter of your cardiac output goes to your kidneys. And you have way more kidney than you need. That's why you can donate a kidney to another person and still be perfectly fine. But that's also why if you get kidney failure, you're in deep trouble. So when you're giving someone a diuretic, you're messing with a really important part of the body's ability to regulate itself and to regulate its ability to filter out and excrete substances that are not good for it, like extra acid. So keep that in mind as well. So how do diuretics work? Well, diuretics work in that they get rid of extra water. Well, how does your body keep water? Your body keeps water mostly by retaining sodium. That's because sodium has an osmotic draw to it, and water will tend to follow sodium. Now, what is osmosis? Well, I don't want to go through all of chemistry, but if you can't remember exactly how osmosis works, the best way to think of osmosis is think of osmotic pressure as like a sponge. So sodium acts like a sponge. It sucks water with it, all right? Now, other things that suck water with them are sugars. So molecules that work like sugars are sugars and sugar alcohols. Sugar alcohols are molecules like mannitol, xylitol, sorbitol, things that are artificial sweeteners that end with tol, things like that. All right, so those are going to be osmotic sponges, if you will. All right, so keep that in mind. Now, you'll probably remember from A&P, you're going to remember not a picture like this. This is my own little interpretation of how the nephron works in the kidney. What you're going to remember is something more like this. All right. I'm sorry to say I can't remember what book I got this from. This is from a picture I got from 2007. I apologize to wherever I got it from. But you're going to remember this horrible diagram, right? Because you're going to remember that the kidney works by the blood is strained like in a big spaghetti strainer through the glomerulus. And then the blood goes through the proximal convoluted tubule through the loop of Henle, which at least that was easy to remember because it's shaped like a loop and it's the loop of Henle. And then there's that weird transporter in the loop of Henle where all sorts of electrolytes get transported. There's the potassium and sodium, and chloride and magnesium and calcium. And then in the distal convoluted tubule, there's other transporters. And then in the collecting duct, there's other transporters, and there's aldosterone and ADH, and then it makes pee. And then remember there was the osmotic gradient. I mean, it's super complicated. But if you think about it, I do need to do an interpretive dance for a second, so I'm going to stop sharing for a second. So if you can imagine, there's the glomerulus here, right? And then actually I can I can do an interpretive dance. So here's the glomerulus, and then it comes down to the distal, the proximal tubule, the loop, and then it comes up, and then the collecting ducts, right? So if you imagine taking all that business, right, and just straighten it out, okay, with the glomerulus at the top, right, and the fluid going down all the way to the distal convoluted tubules and the collecting ducts at the bottom. And at the bottom, pee comes out, okay? So I'm taking the nephron and just straightening it out, all right? That's what I've done in this picture. So I'm going to share screen again. All right, so what do you really have in the nephron? Don't worry about the gradients, or it doesn't even matter in terms of pharmacology, the names of the glomerulus and the proximal convoluted tubule and all that stuff. If you were like really a star in A&P and you have that stuff memorized to the T, fantastic. I've given you the names, the anatomical names of those areas here along the side. You are amazing. That's fantastic. But you don't need it. All you really need to know is about 3 little, or 4, but really just 3 transporters, okay? So imagine that the glomerulus is at the top, and that's where the blood is being strained like big spaghetti strainer. Just all the juice of the blood, or, you know, the plasma, right? Whatever. The human juice the blood juice is being strained out into the nephron. What your body does is there's transporters between the bloodstream and the proximal convoluted tubule, the very beginning part of the nephron. The body just takes back what it wants. And then everything else gets excreted. That's why it's so important that you have those phase 2 reactions in the liver, the phase 2 metabolic biotransformation reactions in the liver, because that makes all molecules that your body doesn't need anymore. It makes those molecules charged so they're water soluble, so that when everything gets strained through the glomerulus, those things are water soluble and they just get washed away into the urine because they didn't get taken back by the special transporters. They just get washed away if they're water soluble. Okay. So the first thing you have is something to get rid of all that acid that the body made. All right. And that countertransports sodium for acid or protons, H+, right? So that's one transporter. And you're going to see a common thread here, and that's that your body is always taking back, basically after you've strained everything and taken back everything that you want, all you're doing for the rest of the kidney pretty much is getting water back, is retaining water. Because if your cardiac output, a quarter of your cardiac output is to your kidneys, and you didn't get all that water back, it would be like only a few minutes and you'd be all shriveled up like a raisin because you'd pee all your water out and that'd be the end of you. So your kidney has to get back all that water that got strained out. So the way it does it is it takes back sodium and then the water follows it wherever it can. So this interface between the bloodstream and the nephron tube is pretty much waterproof, except for a few spaces where there's these pores called aquaporins, and that's where water can transport between them. And as long as the sodium on the bloodstream side is higher than the sodium on the urine side, the water will go to the sodium side. So you have 4 transporters, all of which are transporting sodium back into the bloodstream. So if you ever can't remember, which way does sodium go? It's always going to go from urine side to bloodstream side. The sodium here I've labeled, and it's in green. If you can see green, you'll see that those are all, the sodium is always going back from the urine to the bloodstream in the natural state. All right. There's a spot where water can go back from the plasma side to the bloodstream. It doesn't matter where these pores are in terms of understanding pharmacology. Just know that there are pores there. All right, so here at the proximal convoluted tubule, we have sodium acid countertransporter, okay? Here in the loop, we have a very weird transporter called the sodium potassium 2Cl pump. That's because a sodium, a potassium, and 2 chlorides are all pumped the same direction, because it has to be sodium and potassium are both positively charged, and then you need 2 chlorides to transport it. And then there's also magnesium and calcium and stuff like that, but we don't care about that. All we care about is sodium and potassium. And the reason we care about potassium will become clear shortly. All right. So this weirdo pump in the loop of Henle is a very important pump in terms of diuretics, because there's a whole class of diuretics called loop diuretics that are incredibly powerful. And they're incredibly powerful because this weird loop pump here is unlike any other pump anywhere in the body. So you have this a whole class of diuretics called loop diuretics that are very powerful, that can get a lot of urine out of a person very fast. And in fact, they're called high ceiling diuretics. And the reason I think of them as high ceiling diuretics is I think of, you give the patient the loop diuretic, and then the room fills to the ceiling with urine. So that's how I think of loop diuretics. Okay. And then later on, a little bit farther along the nephron, you have another pump, which is sodium and potassium also going the same way. Okay. So sodium and potassium are going the same direction. That's very weird, right? Because almost every sodium potassium pump you've ever seen, the sodium and potassium are going the opposite way. But here, sodium and potassium are going the same direction. Super weird, right? And then in the collecting duct, you have sodium and potassium going the good old-fashioned way of sodium and potassium going the opposite direction. Now, this pump here is modulated by our buddy aldosterone from the renin-angiotensin-aldosterone route. So aldosterone, one of the big ways that it regulates potassium levels in your body is by regulating this pump, right? So if it increases the action of this pump, that means more potassium will leave your body. Now, if we block aldosterone with an aldosterone blocking drug, then less potassium leaves your body and the potassium level in your body goes up. Make sure that that makes sense to you. Stop the tape. It shows how old I am. Stop the video, rewind, and listen to that one more time. And we're going to go over it again in a second. Okay. So again, we have 4 pumps. We have the sodium acid countertransport. We have sodium potassium going the same way in the loop. We have sodium potassium going the same way in the distal convoluted tubule. And then we have sodium potassium countertransport. This is all the nephron physiology you really need to know for pharmacology. Okay? All right. Now, the rest of all this words summarizes what's in the next 2 pages of the handout. And if you're not taking my class and watching this, you can find my handout at LineaBoyev.com or just Boyev, Boyev.com. Okay, so let's talk about these different classes of diuretics. This is the placeholder.